for the Health Economy at Macquarie University. This is our second seminar of 2023. First of all, I'd like to acknowledge the traditional custodians of the Macquarie University land on which we meet, whose cultures and customs have nurtured and continue to nurture this land since the dream time. We pay our respects to elders past, present and future. Today we have a very exciting presentation. It is titled Measuring Outcomes and Comparative Value in the NDIS. Obviously, the NDIS has had a lot of coverage over the last few years, and it will most likely to continue being a hot topic amongst the debate. But Dr. Andy Goodall, who's the Director of Targeted Research and Strategic Evaluation, today is here to talk about how the NDIS measures outcomes and how it looks at comparative value in the services that are delivered. So without further ado, I'd like to hand it over to Andy.
Brilliant. Thanks, Henry. Okay, so just to start, I'd also like to acknowledge the traditional owners and custodians of the land we're on today. So it's the Gadigal people of the Eora Nation and their continuing connection to land, sea and community. I pay my respects to elders past, present and emerging. And I'd also like to extend that acknowledgement and respect to any First Nations people here or on the line today. So there's a few things that I'll talk about today. So just to start with, I'll just give a little bit of an overview of the NDIA's research and evaluation branch. It's a rare beast in the Commonwealth Government to have a dedicated research and evaluation function that has the level of investment we have and then actually does the type and the amount of in-house work that we do. So I'll give you a quick overview of that. Then I'll give a bit of an overview of how the NDIA measures outcomes for NDIS participants and how it reports on those outcomes. One of the ways, there's a couple of ways, but this is the main way, and some of the challenges that we face with that. And so then I'll talk about a couple of projects that we're working on. One in-house, which is where we're trying to look at new ways to use the data we have to improve our ability to understand the outcomes for participants in a digestible way. And a project that we're doing with, or being led with Macquarie University, Monash University Centre for Health Economics to develop a disability wellbeing index, so like a quality of life measure for disability. And then just finish up with a little bit of an overview of some of our research priorities that we have, potentially how others might get involved in that. So the research and evaluation branch. Look, undertaking research and by extension evaluation and building an evidence base is actually in the NDIS Act, which is a great place to start with. And it's also integral to the insurance approach that underpins the NDIS, so Principle 3 specifically. So we've immediately got a great mandate for a decent agenda in that space in the NDIS. The research and evaluation branch kicked off in 2019. I was one of the first 4 staff members. So I've seen it grow, been along with the journey. And basically we have a responsibility for ensuring that NDIA policies, practices and priorities are informed by trustworthy and robust evidence. So we're up to our second strategy, 5-year strategy, the second one. And really that strategy gives us a mandate to generate evidence of what works, testing innovations, so pilots, randomised controlled trials we're starting to get into, really how we measure outcome and benefit of the things we do, and by extension those techniques can be applied scheme-wide potentially. And then we've got a function to turn evidence into action, so a research translation function, a dedicated team for that. And that focuses on supporting our participants understand what evidence-based interventions are out there, how to navigate a complex market and find the right type of supports for their needs, but also internally how to take some of our learnings and put that into the way we support participants. So under the strategy, our work is broadly divided into 4 streams. We do a little bit of work outside of this, but generally there's a major body of work around information gathering for NDIS access and planning decisions. So some of you who follow the NDIS might remember the fated independent assessment pilot, which never to be spoken of publicly, and I just committed a huge sin. But this is essentially a follow-up of that, where a process has been co-designed with the disability sector. So we're involved in that. Early intervention and high volume cohorts. I mean, high volume is a no-brainer. High volume equates to a large amount of need, but also kind of cost of the scheme. And early interventions are part of the NDIS. That's very important because it can reduce demand for the scheme. So whether that's diverting need to become a full lifelong scheme participant, or maybe to be able to support participants and their families build enough capacity to reduce their intensity of need for the scheme. So a lot of work around that. Home and living is big business in the NDIA. A lot of our participants require some form of support, including 24/7 support. Models of support can be, certainly based on legacy models and not necessarily providing the best experience for participants and quite expensive. So that's an area. And markets and employment. And, markets is a no-brainer because the scheme is a market. The NDIA helps steward or manage that market. We actually aren't the main player in the NDIS. It's the market. That's the main player. So, understanding how to get an effective market operating, particularly thin markets. So, think about remote locations where it can be difficult to get supports, has flow-on effects to our participants, obviously a big area. If anyone's interested, you can just go on to just plug in NDIS research and evaluation strategy and you'll be able to find more information. So what we do as a branch, broadly speaking, these are the activities. We undertake data analytics and outcome measurement ourselves. We've got a team of biostatisticians, econometricians, epidemiologists, all taking all of the scheme's data and then doing as much as they can with it, but also thinking about new ways to use that data, thinking about ways we can get more value out of the data to be able to give an indication of how we're tracking as a scheme. We've got a dedicated team that do a lot of systematic reviews and meta-analyses, and that's really around trying to understand some of the evidence base behind some of our higher cost supports generally. So, think about certain behavioural interventions, big cost of the scheme, what's the actual evidence base for the way those are delivered, the dose, those types of things. So they're off beavering into the literature, doing that type of thing. We do a lot of qualitative research. Try and talk to our participants as much as we can, see what they think. We try and talk to the sector as much as we can to see what they think, and we try and wrap that around a lot of our quantitative research, which we also do. We've also got a role in building capacity in research and evaluation methods across the agency. We do a lot of the research and evaluation, but by no means all of it. So we need to make sure, and that's a capacity issue, that we need to make sure and support other areas of the agency conduct their research and evaluation in such a way that it's going to give them evidence that's acceptable for them to go forward and make decisions with. And we also govern a lot of the research and evaluation activity across the agency.
Do you also link with external research bodies, universities?
Sure do. Yeah. There you go. So who we are. So we've got, I think, 27 FTE. I think it's about that. And they're all aligned to our major approaches and they're organised in teams. Pretty experienced bunch running all of the units, a lot from academia who've come into the agency. Myself, I've kind of predominantly got a consulting background, so a little bit different to some of the others. We have people who've come from the disability sector in our team, clinical experts. So we've got about 12 projects going on in-house at the moment across the team, but we also partner with externals. So we're currently partnering on 3 Tier 1 grants and some sort of involvement or support 17 other external research projects, predominantly with universities, a small number with organisations within the disability sector. So that's a bit about us. So how do we measure outcomes in the NDIS? few different ways, but the main way we go about it is we use what's called, we have an outcomes framework, a participant outcomes framework. That kicked off in 2016. And the idea is that it takes a longitudinal view of the impacts of NDIS at an aggregate level, but also you can look at the impacts on for individual participants across 8 domains, or maximum of 8 domains, and they change depending on the life course. So you'll see we've got 4 participant surveys. Obviously, the kiddies don't do the survey themselves; their parents do that survey for them. And these are administered in 2 forms. So there's a short form, and participants or their supporters, which is generally their family members or some sort of advocate, run through the questionnaire at their planning meetings or their plan review meetings. So that's got, if you take out the qualifier questions, sort of around 30 to 35 separate questions, and they're split across a number of domains. So in the adults, you can see there's choice and control, daily living, which is really around those day-to-day activities that we might do, such as communication, travel, get tasks done around the house, those types of things. Relationships with family and friends, your home living environment, so whether you're happy with where you live, whether you feel safe where you live, those types of things. Health and wellbeing, lifelong learning, which is health and education, work, obviously employment, and a big one is social, community and civic participation, which is that and work. So economic outcomes are very embedded in the NDIS Act. So they're key domains. So that's consistent across the 15 to 24-year-olds and the 25 pluses, and then the domains are a little bit different for the younger participants. Now, a longitudinal sample, representative sample of participants complete a longer form of that outcomes questionnaire annually. So that's conducted by an external organisation, and that gives us an opportunity to track participants over time, the same participants over time, to see how, with time, in the NDIS, which outcomes are shifting and which ones aren't, and for which participants. So the way it gets reported, and this is quite small, so apologies for that, but this is just ripped out of the annual outcomes report that gets released, and there's a link there, but every year a giant report, like literally hundreds of pages, summarising all of these outcomes gets released from the scheme actuaries area. And so that report's literally indicator by indicator across all of those domains. It starts to look at break it down into length of the scheme. So that's great, right? So that gives a really good view, really holistic view of outcomes for our participants. It's a real strength of the outcomes framework is how comprehensive it is. It covers the areas that are important for both people with disability and government. So it ticks both of those boxes. But we're talking 30, 40 indicators all reported individually. So you can imagine the complexity in trying to make sense of that. So if you're trying to evaluate the effectiveness of the NDIS, or if you're potentially making an investment decision, or you're doing a piece of research and evaluation of a particular policy or something, you've got all that information to go through, all of those separate models that generally need to be run, a bunch of results, and you've got to sit there and work out, well, actually, what's important. Some things go up, some things go down. So really, really difficult to make sense of. But again, if you're running an employment intervention or an intervention targeting social and community participation, and it's great. You've got a set of indicators that you can specifically focus on just to look at those areas. So it depends on what you're looking at, but in general, for investment decisions, it is a difficult beast to use. So as the main in-house evaluation area, the agency, and we get tasked with trying to understand or report on the impacts of fairly major policies that aren't specifically targeted at certain outcomes. They could be across the lot. We scratch our head and just how do we actually do this? So the question we've been asking ourselves, how do we reduce this complexity into something that's manageable and digestible? It's not easy. So I'm just going to go through one of the projects that we're working on fairly briefly. And so participants with a psychosocial disability are a substantial cohort in terms of size and the size of their NDIS packages. In the scheme, based on the data that we know from that outcomes framework and also from qualitative or anecdotal evidence, aren't really faring that well as a result of the NDIS, aren't really achieving the outcomes we want. We decided to focus on that cohort and do some latent transition analysis and growth mixture modelling. I'm not a statistician, so don't ask me too much detail about it, but Jeff Hammond, who's there, who's a very gifted PhD epidemiologist with a strong grasp of psychometrics as well, has been leading this work. That's literally how he works. It's probably not kosher, but that's fine. Obviously, churns out good work, we'll let it go. So, look, some of you will understand these, some of you won't, so I'll just give a quick overview of these. So, look, latent transition analysis, or LTA, it identifies distinct but unobservable classes of individuals based on categorical data about them. So they're the X's. And it characterises transitions between the classes over time. So in our cases, we've based the classes on the likelihood of participants giving certain responses to items in the NDIS short form outcomes questionnaire. Growth mixture modelling, similar concept. It identifies cohorts of participants based on similarities in longitudinal trajectories on the measure. Really well suited to continuous data. So in our case, we've based trajectories on repeat HUDAS scores. So I mentioned earlier that participants during the plan review time complete the outcomes questionnaire. They also complete what we call severity tools, but they're some sort of functional assessment tool. It varies depending which one is used, varies depending on the participant's primary disability. But if your primary disability is psychosocial, HUDAS is the one used, which is good because it's fairly agnostic to assistive technology, which is not a big thing for our participants with psychosocial disability. So just to give you an example, so this is 15 to 24-year-olds, and just the top part of the titles is cut off, I noticed. But basically, based on the likelihood of giving a certain response, classes emerge. So for 15 to 24-year-olds, we have a 4-class solution. The percentages within each of those classes is at the top of the columns. And the colours just code for how close you are to one. And you can look at that pattern and start to make some judgments about what a desirable class is. Now, it's subjective, but in this case, we look at class 1 being the most desirable based on the pattern of responses. They're the class that's most likely to make decisions for themselves and know people in their community, so potentially have more autonomy and are getting out and about more. They're quite likely to participate in education and training, and they're likely to feel safe at home in the community. You can go through the whole list and see how that pans out. And then class 4, based on those outcomes, which just from within our team, we've just said, okay, we think they're the most important, just because this is a developmental approach at the moment that we're still working on. We've deemed that's probably the least desirable class. But like I mentioned, class ordering is subjective, so it's good. But who are we necessarily to say which outcomes are most important to NDIS participants without asking them, right? So we're making judgments, and it's difficult. We actually don't necessarily have any empirical evidence about until literally the last couple of weeks, about which outcomes are the most important to participants. So growth mixture modelling and those trajectories, it's more objective, right? So HUDAS is the HUDAS. We're not making a judgment about anything in the HUDAS, just the raw score. And clearly you can see that some trajectories are based on others, depending on whether the scores decrease, which would indicate the participant's functions improving, or whether the scores increase, which indicates whether functions deteriorating. We also can see whether participants are staying the same, so their functions maintained, and that's always been something we found difficult to look at with our participants' maintenance, which we focus on improvement, which is great, but for a lot of participants, maintenance is a great outcome. So this gives us quite a nice way to be able to look at that too. And as I mentioned, the WHODAS is great because it's a widely used and validated measure of disability for people with psychosocial disability. It's agnostic of assistive technology, which suits that cohort well. If you were to apply the WHODAS to another cohort, for example, intellectual disability or someone with a physical disability, it starts to get a little bit difficult, the framing from which they're answering from. But for psychosocial disability, it's spot on. So what we found, we tried to reduce complexity, and in some ways we increase complexity. So we have the opposite effect, which quite often happens, but that's all right. So we've only looked at this for participants aged 15 and up. And if you look at our outcomes framework, we've got 8 domains across those 2 age groups. The domains are consistent, the items are largely consistent. But we, basically, if you're 25 years or older, same indicators. So for the LTA and growth mixture modelling, we actually found that the optimal solutions varied 10-year age brackets. Right? So that says to us that those patterns of responses and those trajectories really do depend on how old you are. So whether it's actually appropriate to look at such a large window that we do, probably not. But we've also created a situation where we actually need to start thinking about things at a much more granular level. That's okay. So how are we using this? Or how are we starting to use this? So straight off the bat, I think we've got more sensitivity. I think we do have a simpler way of looking at things. Because a challenge we've got with the framework, the NDIS outcomes framework, is that a lot of the items are binary. So we see floor and ceiling effects a lot. Necessarily able to measure incremental change. We report, as I mentioned previously, longitudinal change in each individual indicator. Let's say we see typically a 5 to 8% change over time for participants with a psychosocial disability. Unfortunately, that's generally accurate, but not always. So i.e. outcome attainment is not going in the direction we want. But as I mentioned before, we've got some outcomes are improving, some are deteriorating. How do we know which outcomes are most important? Based on those patterns, how do we actually get a picture of whether the lives of NDIS participants are getting better overall? The individual indicators, really tough. So the bottom left, that's typically how we work. Individual indicators, complex. If you look at the right, so this is the, we just looked at whether participants age 25 plus, so ignored their 10-year age bracket, but looked at how many actually move into what we consider a more favourable trajectory, growth mixture modelling. Pretty straightforward. You can see that from the trajectory of their WHODAS scores, the percent that maintain their class or trajectory, so i.e. their level of function or disability staying the same, and those that move into a less favourable trajectory. Now you can certainly see with both approaches, we have more participants that are deteriorating, that are improving based on those trajectories or classes. A lot of maintaining, but you'll see with growth mixture modelling approach using the WHODAS data that our sensitivity has increased. So we've gone from being able to detect movement in 10.8% of participants up to, 47.8 participants. We can detect, some sort of improvement or deterioration, which is great for us because it means we can start having a closer look at the things that are associated with a change in outcomes, which is quite difficult. So, look, based on that, we think growth mixture modelling is attractive. Like I said earlier, different disability cohorts complete different assessment tools, which makes it difficult. We can't really compare between disability types. There's also the element that the agency are used to reporting on the outcomes framework. It's the accepted way of reporting to actually start going and reporting outcomes based on those severity tools such as the WHODAS. is definitely a shift and will require a little bit of kind of change management, change thinking for that to become a legitimate way that we make decisions. Part of that's because it's a little bit less tangible to report than saying when someone's participating in a community group or has a good relationship with their family. It's a more difficult story to craft. So ultimately what we're interested in doing, and there's a really large body of work going on in the agency called the Investment Effectiveness Program, which is really trying to predict the value for money or the benefit of NDIS supports with an aim of trying to understand what's an optimal package of supports to achieve outcomes.
I've just got this question which keeps on occurring to me as you talk. I'm sort of professionally involved with the NDIS. I'm a lawyer who advises disability organisations, and I'm personally involved because I've got a son who's got severe autism. And I just keep on thinking, you talked about those two questionnaires that the sort of source data. And the first one is the questions answered at the review meetings.
Correct.
And I think that data is, I think I'm sure you must be, must consider this, but it's got a high chance of being inaccurate in the sense that, having gone through reviews, you're trying to give them the answer that will get you the support you want, rather than necessarily answering what's actually happening.
100% agree. 100% agree. There is that. The other aspect of it is as well, and there's a few giveaways in the questionnaire. There's a few items where you can actually tell whether the survey's even been administered. And we think potentially up to 18% of the surveys aren't administered. So they're just copied over from the previous time. So we delete that, we exclude that data. That'd be a lower estimate. That's what we can be sure of. I suspect it's higher than that. And that all comes down to time pressure, basically. Planning that into time. You think about your partners in the community, so local area coordinators who are doing a lot of those plan review meetings, contracts, time is money, those types of things. So, that happens, unfortunately. Yep, so spot on, really good observation, and glad you brought it up. All right, so we're looking at expenditure. So if we look at single outcomes, and we typically see a marginal effect of around plus or zero to plus or as in nothing to plus or minus 2% change in the likelihood of attaining an outcome for every $1,000 spent per annum in the NDIS. That's typically what we see. That's not doesn't hold for everything, but based on our work, that's about where we're at. Others may, in the agency, using different techniques, may come to a slightly different answer, but the marginal effects aren't great. Capital expenditure, so your assistive technology. So if you think about an assistance dog, for example, or some sort of technology to help a person with disability drive, much bigger effects. But a lot of our expenditure falls into what are called core and capacity building buckets. Core are things like 24/7 care, home care type things. Capacity building would be a lot of therapy and skill building type activities. The idea behind those is to build a participant's capacity so that they can do more things independently and potentially, in theory, need a little bit less of the of support from the NDIS. So, we don't really know, like I've mentioned a couple of times, which outcomes are more important, which raises the question, which funding mix maximises benefit. So, look, just really early work this, but we've looked at those core and capacity building budgets. And what you can say using our techniques is that the effects are inconsistent. So if you just look at raw expenditure, it could be, could increase the likelihood of improvement or decrease the likelihood of improvement, or same for deterioration. So it's quite a complex story. Probably say maintenance is the main outcome, maintenance being the reference case here. What we really need to do to understand this in a lot more detail, because we think this has a fair bit of potential, those two buckets are divided into and probably another sort of 12 other buckets of funding, which are called support categories. There's 15 all up. Some of those are around capital. We really need to understand which support categories. So do this analysis by support categories. What we also know is the clinical diagnosis. We know that where someone lives, so their remoteness, we know their age, we know the length of time they've been in the scheme, which is mentioned there. They're all associated with the likelihood of improvement or deterioration. So we're now at the point where we need to start to understand the interactions between those factors and expenditure on a more micro level. Where we want to go with this is potentially be able to inform a methodology for the agency to start thinking about life stage specific NDIS packages. And by life stage, that's also age, but also, if you're attaining this mix of outcomes, okay, the next logical step is to, start thinking about these types of outcomes. What package is going to help you get from there to there? So not necessarily to jump from over here to over there, but those incremental steps. That's sort of where we'd like to get. That way we can provide our participants with some information, some knowledge that, or their supporters that, hey, you want to achieve this mix of outcomes. These are the types of supports you might think about looking for. So, project we're doing, it's related, but really exciting work. We're not doing it in-house, we're supporting it, is we're trying to develop a disability wellbeing index. So, quality of life measure for disability. So, like I said, it's being led by the Centre for Health Economics at Monash University. So Anthony Harris is the lead professor. Gang Chen is the person who is really running the project, and Dennis Petrie is involved. Terrific mob to work with, and they're collaborating with the University of Sydney. So Gwyneth Llewellyn and Kim Bogelli at the Centre for Disability Research and Policy, and the Caring Futures Institute at Flinders Uni, and specifically Julie Radcliffe. So we're about sort of halfway into this project. So what does the NDIS need? Wellbeing index. Right, so these numbers are already outdated. They're outdated every 5 minutes. But participant costs in 2021-22 were 29.2 billion, and projected to be up around 60 billion by the end of this decade. So we're talking exceeding Medicare very soon, which is quite extraordinary, considering there's half a million NDIS participants. It's crazy. So I think what hopefully has come through up until now in my talk is that our current outcomes framework doesn't really support an equitable assessment of NDIS impacts, hence doesn't really support resource allocation. It's complex, as we mentioned, a lot of different scales, so it's really difficult to aggregate. We've tried to see if we can aggregate into reliable and valid measures, and we can't. There's a couple in there, embedded in there, but generally it's not possible. We've got floor and ceiling effects. Some of the outcomes aren't actually outcomes that are realistic for NDIS participants. So you think about the need for the NDIS in various aspects of function. That need actually is why you're an NDIS participant. So you could argue, based on the comment previously, who's actually going to answer that they don't need the NDIS in that area, because it's going to affect potentially their ability to continue in the scheme or the supports they get. But part of being in the NDIS is that your disability is likely to be lifelong, so there's a fair chance you are always going to need support. The other, and really the big four, is that we weight all items and domains equally for all participants. Now, we know that's an invalid assumption. That's never been tested. We've just had some data looking at the domains and looking at the relative importance participants place on them. And they are wildly different in terms of importance to participants, and in some respects the reverse of what we think as an agency, which is fascinating. So 2017, David Cullen, who some of you know, the former scheme actuary Sarah Johnson, put a paper up to the NDIA executive recommending that the agency develops a validated summary wellbeing measure of weighting to assist with comparative value for money assessment of technologies and services. So we had some money down the back of the couch a couple of years ago in the research and evaluation branch. I thought, let's get this rolling, and we committed to at least getting through the first stage with the money we had, and to build a case for completing the work, and we have funding to complete it, which is really exciting. So the aim, we just wanted to develop a composite preference-weighted index of wellbeing for people, starting with 15 plus, so as in participants aged 15 years and older, for the reason that there's a little bit of, there'll be work around the younger cohorts around what outcomes we actually measure for those kids. So given that that's likely, or the rumblings are that may be a fluid space, it seemed a little bit silly to invest at this stage, because we do want this to be policy relevant. So there's 3 stages to the project. First stage is to develop the wellbeing classification system, and we are, if you took a tiny bit off the top of that tick, that's where we are. We're basically done. There's just a tiny bit of validation left to do. And I'll go through that today, and then we'll move into a evaluation study where we'll actually start to develop the preference weights and the scoring mechanism. Then we embed it. Don't know how yet, but that's the next step, and the big thing to work on over the next year for us internally about how we actually operationalise this into routine data collection. That'll increase the volume of data, so there'll be ongoing refinement. One thing about the way we collect data in the NDIS, particularly survey-based data, we struggle to reach certain cohorts. So First Nations, for example, culturally and linguistically diverse participants, we really struggle. LGBTIQA plus participants, we actually don't know. We don't capture that. So we really need to, there'll be a process of testing and tailoring for those priority cohorts and refining. So this will be a many year program of work, but we're at an exciting stage now where we can start doing some stuff with it. So look, the principles of the wellbeing items. So they need to be reflective of outcomes that are important to people with different types of disabilities, different levels of function, and who live in different parts of Australia. And I think the key part there is important. The outcomes that are important to people with disabilities. So really, public servants have had almost no role in developing this today. It's almost been exclusively done, decided by people with disability, and a little bit from the disability sector. We do want it to be representative of domains that are policy relevant, though, which is important. So our starting point was Australia's disability strategy. Makes sense. It's the overarching strategy for disability in this country, and the NDIS outcomes framework. And that's okay, because there's considerable overlap between the two. It's got to be easy to understand. It's got to be brief and practical to collect and report over time. Importantly, it's got to be psychometrically valid and reliable. And it's got to be responsive to differences in wellbeing between individuals, and reflect differences in the services and types of supports they receive, which is one of the challenges we've got with our existing data. So the first thing we did have to do it, but it was a good exercise to go through, is we have a lot of data. So let's actually test some of that. Is there any that we can use to contribute to the index? So 86 items were screened from our the short form outcomes framework. And I know earlier I said there was 30 odd items. This combines the 15 to 24 and the 24 plus, and a few of the qualifier questions, but nonetheless the items are screened. 44 were excluded straight off the bat. They were either too broad or narrow. Wasn't clearly a positive or negative outcome, quite clearly irrelevant to wellbeing. Not necessarily the way they're framed, not reflective of current wellbeing of the participant, or are redundant, given that there's other items. So that cut most of them out, or half of them. So the 42 that were left, so there was a fair bit of inconsistency in the way the items were phrased and the response scales, but nonetheless, the guys from Monash still blazed away and analysed it. So they looked at the change in outcomes from baseline, so when a participant first entered the scheme, to their second plan review. So the rationale being, first year in the scheme, you're trying to learn the scheme and understand it. You probably still are in the second year in the scheme. So let's just introduce a little bit of a lag to give a bit more time for outcomes to be achieved. And looked at around 52,000 participants, and all 42 of those items were excluded as being applicable for the wellbeing index because ceiling effects, their marginal, very marginal responsiveness to time, NDIS expenditure, disability type, anything, right? Just really unresponsive. And also there's quite a lot of correlation across domains, which was not ideal. So came to the conclusion that the NDIS outcomes questionnaires are unlikely to be able to detect meaningful differences in important aspects of participant wellbeing, which legitimised us proceeding with the rest of the project. So next step we went through is just having a look at how do other jurisdictions, and what does the literature say around measuring wellbeing. The rationale here was to try and identify, potentially relevant domains, the alignment of that relevance with our ADS and NDIS outcomes framework, which, as I mentioned, have considerable overlap, and some preliminary items and response options to really take forward to people with disability and stakeholders to say, what do you think about this? How do we refine this? What can we add to it? What can we take away? So really develop it with them. Starting point was the ADS, as I mentioned. Excuse me. And what we really compared the domains of the ADS and the NDIS outcomes to was, there's a list of international indicator sets or indices, and also a number of already reliable and valid tools which are applicable to wellbeing. So this is quite complex, but basically, if you look at the middle column, so that's our NDIS outcomes framework, so the bit above the green dashed box. And then if you compare that against the ADS, so Australia's Disability Strategy Outcomes Framework, you see there's a bit of alignment, safety, rights, justice, community attitudes or add-ons. So that's straight off the bat, we added safety, rights and justice to the domain list at the bottom of the outcomes framework. We looked at some of the other indices out there. And this is just an example of the Wales Act, and you'll see there's pretty good alignment there with our own outcomes framework. We saw the same with the other jurisdictional frameworks and indices we looked at. And then based on all of that information, we thought, right, the 8 domains that we've got in our own outcomes framework, plus these extra 3 are a really good starting point to take forward for conversations. People hate a blank page, so good to go forward with something. So consultation phase. So there's a preliminary domains and an item bank. So the way the Monash guys and the University of Sydney team went about it. So initially they took those to disability advocates, so the disability representative and carer organisations, all of the ones that the agency interacts with were invited. 12 participated, so that was great. There was at this point a conversation with government, not so much that within our agency and with the Department of Social Services, not so much around validating what has been found to date and the domains we're going to take forward, but really just to give a lot of transparency about the process. So really get the key decision makers on board and supportive of what we were doing. And then there was 27 people with disability and their carers, so NDIS participants. And really the preliminary domains and items we tested with them, and also a recall time. We actually couldn't get agreement on a recall time because it's different for every disability, so we don't have a recall time. And we updated that initial classification system and then took that forward into focus groups with people with disability or one-on-one interviews, depending on their preference. They were very flexible around this. So as you can see, wide range of people represented in those focus groups, and that led us to a draft disability wellbeing index for piloting. So to give you an idea of how the domains evolved, I won't spend too much time on this, but it basically shows that through iterative conversations with those groups, the number of domains, the labelling of some of those domains, the items within them as well changed, evolved to that final set for August 2022 in the ready pink box. And you'll see that that actually has great alignment to the ADS. So we've come up with a policy relevant set of domains of wellbeing that people with disability have given the thumbs up to that point, which is great. So example of, this is just a choice item. This is the feedback on items. So within those focus groups, 4 options in this case were presented to people, and they were asked the meaning, the way it's worded, clear and easy to understand, and then which wordings or wording they prepare. And you'll see there's 4 options there. And you'll see, you know, the bottom 2 were preferred to the top 2. So that's great. They're the 2 we take forward for testing because they're the ones that people with disability like best. So where we ended up, 35 items, slight variation for the 25 plus and 15 to 24 cohorts, a lot of consistency, still 35 items. And you'll see how those items align to the wellbeing index domains. It's piloted with in an online survey because we did this online, which has limitations, but for where we're at the moment, it was the most practical way. It's why we need to do further testing and refinement later. Just with 28 participants to make sure, does this all make sense? We went back to the sector, 13 this time instead of 12, just for a final tweak, and then also to select the response options. So really small, these slides will be available, but these are the items that were taken forward for testing in the adult. So the adult survey, it's too many there to labour on them for too long, but you'll see some domains have more items than others. And there's concepts in there that potentially are asked twice, but with slightly different wording. Response scales, we tested 4. Overwhelmingly, the participants who did the piloting picked option 2. So how satisfied are you with such and such? None of the time through to all of the time, which is great. That was quite good. So we want consistency of scale throughout the index. That's really important for people with disability. If you start jumping around scales, particularly for some of our participants with an intellectual disability, that can be very challenging. So consistency is great. So the way we went through this, say online panel, so we don't get great response rates to surveys. That's just a fact of life in the NDIS. But we sent out to 18,000 participants, all their nominees who were 25 plus, around 11,000 aged 15 to 24. And we oversampled rarer disabilities and rural and remote. We ended up getting 1,245 respondents aged 25 plus and 397 in the 15 to 24 cohort. So that younger cohort, that's a tough group to get responses from. The challenge is we get a high amount of proxy reporting. It's inevitable given the nature of disability of a lot of our participants. But we got a good mix of disability types and ages represented. We also, using a panel, so pure profile, went out to non-NDIS participants with a disability because we want the index to be relevant for those participants who are they're kind of just outside the eligibility for the NDIS because they also receive support, they get mainstream services. We'd like an instrument that's applicable for them too. In the survey, we asked them how difficult it was to rate each item. We asked them the importance of each life aspect to overall wellbeing. We asked them the actual question itself. And then we also had some other scales and demographic information in there. So we got satisfaction with life scale, an overall assessment of life question, the personal wellbeing index. And so that was important for the validation. So what we found, a 7-factor solution, which is there, and you'll see those factors, or some of them, majority, have a mixture of items from different domains. That's okay. If you read the items, if you think about the domains, there are relationships between them. So that wasn't especially surprising. So the final item inclusion, we've had put some criteria around it. So if there was, greater than 40% ceiling or floor effect, out. If the percentage of not applicable or missing data, or if respondents said they were unsure how to answer a question, that's out too. The respondent rating of importance. So we wanted an item had to have greater than 50% rating of extremely very important, because that's likely to be relevant, important to a large number of people who are potentially responding to this survey. Correlation had to have a minimum of 0.3 correlation with the overall quality of life rating. Within each factor, the item that had the lowest explained variation on the satisfaction with life scale and the personal wellbeing index also excluded. Retest reliability we looked at, so we wanted a reasonable amount of retest reliability. That is challenging because some disability types fluctuate, so you have to be a little bit relaxed with that. And then did some IRT. So if there is response disorder or poor fit, those items were also unlikely to be considered. Then there's some qualitative considerations. We wanted to look at domain coverage, concept overlap. We want a parsimonious instrument. Policy relevance has come into it, but also the ability to profile participants. So outcome profiling. So I want enough things represented, enough aspects of life represented that if we did want to look at individual items, there's actually a pretty good spread there to be able to look at. So there's potentially a little bit of redundancy, but you still come up with a pretty tight instrument. That just gives you an example. The reds are where we initially excluded. Certainly won't go into that in a lot of detail, because this is really the crux of it. So for the adults, I've got 15 to 24s up. We ended up with 13 items. These are the areas. So they're not the specific questions because they didn't fit the boxes at a decent sized font, but you can trace that back. And you'll see we've got really good coverage of the NDIS outcomes framework. The domain missing is work. So all of the items that we tested related to work did not fit multiple of our inclusion criteria. We've done some other work that I mentioned looking at domain importance, and work is by far and away the domain given the least important by participants. It's just not relevant for a lot of our participants. But financial security is. So having enough money to do things. If you think about it, there's more ways to get money than just working, depending on your situation. So then if we look at the alignment of those items with the Australia's Disability Strategy Outcomes Framework, again, we've got great alignment. So we think we've got a pretty good classification system. Just go on to the next steps. Just got to do some final acceptability testing with a group of people with disability, and also present it internally at the end of the month to a senior audience in the agency. Want to get buy-in early because it's going to make it much easier to implement this. Then we move on to that second stage, which is the valuation study. What we want to do with that, we want to have population weights, but we also recognise that there's a real individual component for what's important to people. So we actually want to build in an individual preference weight. Potentially either be a rating or ranking task. We're going to have to determine that during piloting, which way to do it. But we really want to give participants the opportunity to be able to influence their overall wellbeing score by saying the thing that is most important to them out of that list. The target is to have an index, a final index to trial late this year, and then 24, 25 we'll start implementing. We've just got to work out how to do that yet. So we're ideas people, we're not implementers, but we'll get there. So last thing which I was asked to whip a couple of slides at is just, really, how can we work collaboratively on future NDIA research priorities? I mentioned earlier that we certainly partner external. So those 4 areas that I mentioned, which align to our strategy. Now, this is just a list of some of the priorities that we've got in the next few years. So that information gathering for access and planning, that's difficult to progress at the moment with the NDIS review that's going on, because that's certainly well within the scope of the NDIS review. But the other side of that, which will be later this year, there's really going to have to be approaches developed to gather consistent and equitable information to really support access decisions and also planning decisions. What that looks like, I don't know. The NDIS review will give a hint to that, and there's a big co-design process around that. So that's a little bit difficult to guide people on. In the home and living space, we're really, really excited about smart technologies to support greater independence. We really want our participants not to be constrained to traditional legacy models of home and living support, but to be able to have a much more individualised solution that suits what they want, how they want to live. There's obviously risk issues, there's capacity aspects that participants need to be supported in to live independently or more independently. Technology is a great way to start thinking about that for some of our participants. And also thinking about accessible and inclusive houses, the actual stock and development, which is not a strength at the moment. If you think about where a lot of disability housing is positioned, miles away from anything in suburbs without footpaths, is an unfortunate reality at times. Early intervention and high volume cohorts, big one. Really big body of work at the moment trying to understand what is effective intervention, what types of interventions are actually effective for children with developmental concerns, developmental delay. What outcomes should we measure for children and how should we measure them? We've also got a mindset in the community that the NDIS is the first stop. It is for some kids, but there are pre-NDIS pathways. How do we actually encourage greater acceptance of those pathways as an option? Because the uptake is extremely low at the moment. And technologies for participants with intellectual disability for various aspects of their life, which relates to home and living, but more broadly than that. Markets is a big one. So following on, we're going to have a wellbeing index. What's the threshold for resource prioritisation from that? How do we make that decision? We'll need help with that. A lot of help with that. We're going to need to further develop the index and our outcome measurement in general for intersectionality groups. So I think First Nations called LGBTIQA+. I was in a session for our new First Nations strategy that's being developed, and outcome measurement, what outcomes we measure is a massive focus of that. So there'll be work there. We've got a problem with thin markets. We have challenges getting providers to establish services in remote locations. Tele-enabled services is a solution to that. They're surprisingly few or infrequent in the NDIS. How do we actually increase that? What type of services are applicable for that? And then alternative commissioning models. We're always interested in understanding different ways we can commission to encourage service providers to get more involved. So I'm just conscious of the time because I know it's right up to, I've only got a couple more slides. Oh, one more slide, really. But look, we can help researchers in the disability sector carry out work that benefits our participants and relates to our corporate plans and priorities. This can be through access to publicly available data. We can help facilitate access to tailored data. We have a lot of data. We have like hundreds of millions of rows of data. We can help people that get access to that. We'll put a case forward to access that. We can help with access to staff, study subjects, participants to study subjects. We collaborate, partner on research and evaluation projects with organisations such as yours. So really, if you go on research partnerships on our website, it'll give you information about how to put in an expression of interest, and we have a process of appraising those and reaching out and making contact. I'm conscious of the time, so I'll skip the last slide, which just tells you about how you can access data, but the slides will be available so you can have a squiz at that. Thanks for listening.
Great, thanks very much, Andy. Look, we have run out of time, so we can't ask any questions, but what we will do is, can we make this video available? We've been recording it, and your slides also, and have you got your details on those slides, your contact details? Yep, that'd be great. So if you've got further questions, please reach out to Andy. We'll get a set of slides that has his contact details on there as well. And thank you for attending the seminar, and thanks to Andy.